Hello, I'm Dr. John Kruse, and today I'm going to be talking about are high doses of stimulants a bad thing? So I'll be addressing chronic ongoing prescription use of stimulants and whether high doses are dangerous or something to be always avoided, or whether they may actually be beneficial to some people. As usual, I'll start with the take-home message. I'll summarize things in about a minute or two and then launch into the main topic. So the take-home message is that certainly individual prescribers often are getting feedback from patients that they're hearing this doctor says, oh, I'm never going to prescribe more than 30 milligrams of this drug, or no, I don't go that high. And there's a lot of publicity in the general media about how dangerous big doses of stimulants are, and nobody should be on any dose bigger than X amount. I would say in general, the benefits and risks of any medication do increase with the dosage. Some are linear, some are different patterns of increase of benefits and side effects. And so there are risks the higher you go. Most of the risks for stimulants are what I would call nuisance risks, so they are not life-threatening. They can be highly annoying, highly disruptive. It could be agitation, insomnia, decreased appetite. But much of the concern around the higher doses of stimulants is about the dangerous risks, risks of addiction, risks of psychosis, risks of cardiac toxicity. And certainly at really high doses, those are profound risks. And there's a lot of pushback in the media, particularly from one study that was released in the last year that claims that there's no added benefit for anybody from going higher than a standard dose. We'll talk about that study in more detail. So my bottom line is we should still treat patients as if we're talking to individual human beings. They are not data points. We should inform people about risks and benefits, but there are clearly, just by how everything works with humans and animals and life, and there are a broad range of responses to any medication, any substance. We should inform people, again, what the potential risks are, but also of the potential benefits, and we should be observing what effect this is having at this person at this time. The good thing is that many of the benefits certainly, and many of the risks also show up pretty quickly with stimulants. So compared to some of our other drugs, they are easier to dose than something like an antidepressant, where you might not know for a month whether it's really working or not. So that's the take-home message. So in the US, the FDA is the government agency involved in approving drugs, and before a drug is approved, a pharmaceutical company has to present studies, phase 1, 2, and 3 studies. The first phase studies are just looking at safety, so they're giving different dosages of the drug, often including dosages bigger than are ever going to be recommended, just to see how risky or dangerous those are. Usually those are done in healthy volunteers, often not even those particularly who have the condition that's going to be treated. So there's some baseline safety data, but it's limited numbers of people, looking at tolerability as well as safety. The phase 2 trials are then efficacy trials, which are looking at, does this really work for the condition it's supposed to be working for? And then fairly small numbers of people can give an indication of whether drug X is likely to work. And then there's phase 3 studies, which are more like real life modeling, where it's a broader range of patients with different ages, different genders, different severities of the condition, seeing what we're seeing, what we would expect to see in real life given this drug over a range of dosages in terms of both benefits and side effects. Now, when the FDA approves a drug, it does approve it within a recommended range. Now, part of that, what the FDA winds up recommending is influenced not just by the FDA's judgment. I mean, the FDA makes a final judgment, but the drug company can also influence it. I mean, certainly influences it, and often they err on the side of caution, knowing, oh, that other rival company got dinged and rejected for, at the higher end of their dosage range, there were side effects or problems, so we're only going to request these dosages in a lower range. So drug company modeling or market behavior is one of the factors that goes into what the final FDA recommendations. The FDA is recommending dosages, though, that they think are both effective and safe, and are going through a cost-benefit relationship between the two of them. Now, the FDA recommendations are not explicit limitations. The FDA very clearly, very explicitly, a lot of doctors, even a lot of pharmacists, don't seem to understand or get this. But the FDA says in its own writing that it is not dictating prescribing practices and that their recommendations are not a substitute for individual medical judgment. Well, so part of, again, doctors' fear of going higher, one is maybe their own limited familiarity or comfort with a given medication. But doctors are facing increased threats of prosecution. Part of it is more DEA than FDA. So as part of the opioid crisis, response to it, which has brought down levels of prescribing of opioid prescriptions substantially. Whether that's solved the underlying problems or not is a different question. But the DEA is investigating pharmacies more closely, is investigating doctors more closely, and some of the red flags for showing up in different systems are higher than average dosages of controlled substances, including stimulant medications. So many doctors worry they'll be flagged, they'll be investigated, they'll be prone to lawsuits, and doctors not only need to be following FDA recommendations, but if they are following community standards, they are protected somewhat by that. But most importantly, a doctor's protected if they document in their notes that what they are prescribing is not producing any apparent side effects and is having the beneficial effects that the medication was intended to provide. That's the best protection against lawsuits and prosecution. The other pressure doctors are getting for not prescribing high doses is from the insurance company. And the insurance companies, I think maybe 50 years ago, many people who worked in the insurance industry really believed they were providing a service, protecting people from financial calamity, big expenses for medical bills. I think now, for many decades, it has been clear the insurance company is what runs the medical complex in America. They are not particularly at all concerned, despite what occasional advertisements might say about individual health. They're not even particularly interested in group health averages, except to the extent it makes them money. These are for-profit, money-making institutions, and part of how they make money is by reducing the outflow of services that they're going to pay for or medications that they're going to cover. So there's considerable pushback there. It often is difficult to get insurance coverage for dosages higher than standard rates, and highly disappointingly, almost always even clear-cut documentation that a drug is effective at a higher dose and is devoid of adverse effects at that higher dose is not sufficient for many insurance companies to approve it. Almost always they require, show us peer-reviewed papers that say this dosage could work. Why that would be more convincing evidence than documentation about the patient themselves is not clear to me, but that is part of how our current system in the US anyway is built. So jumping back to the FDA, one thing that anyone who's looked at the numbers is aware of is that the numbers or the dosage ranges that are approved or recommended are not even particularly consistent. So I'll not go into the minutia here, but in general, 40 milligrams a day is a recommended higher dose for ADHD, but substantially higher doses allowed for narcolepsy. Does that mean narcolepsy really is harder to treat, or that people with narcolepsy are really more resistant to side effects at different dosages, or that narcolepsy is actually any more impairing or serious than severe ADHD? those are all weird judgment. So 40 milligrams a day for Adderall, but only 60 milligrams for methylphenidate or Ritalin. Now, almost every bioequivalency would suggest that methylphenidate is only half as strong as Adderall. Ritalin, so Ritalin is only half as strong, so you would think if FDA is saying 40 is a maximum dose for Adderall, shouldn't they say 80 for methylphenidate? Probably they should. I mean, again, I'm not going to go into too much detail. Vyvanse, again, remember, because Vyvanse is linked, the dextromethamphetamine is linked chemically to the amino acid lysine. Only 30% of the weight there is, after it's split, is active dextroamphetamine. But the numbers, what's approved for Vyvanse don't correlate that clearly or to what the Adderall dose should be. So 70 is the biggest dose of Vyvanse approved. That's only about 21 milligrams of Adderall. In general, most of the experts would say that your total daily dose of immediate release stimulant, so if you're taking 10 milligrams, 10 milligrams 3 times a day, that should be roughly equivalent to 30 milligrams of an extended release formulation. But if that extended release formulation is only delivering 30 milligrams over 10 or 12 hours, as Adderall XR might, compared to, let's say, 16 hours, like Metadate does. Sorry, Mydayis does. Mydayis extended long half-life. So don't delve into this expecting that there's any logical consistency or they're following some absolute scientific standards. These are judgments, again, partly influenced by what the drug company asked for, partly dependent on what the whims of the FDA when they approved a particular drug in a particular year are. So I won't go into that in more detail, and again, different half-lives, and I should not be saying half-lives because half-life technically is the time it takes half the drug to leave your system. We're talking usually effective lives for these longer-acting medications. So jumping away from what the FDA allows, looking at why doesn't everyone need just 25 milligrams of Adderall a day? Why is there so much individual variation? And we know a lot of different factors can contribute to individual variation in terms of what is optimal for a given individual. So absorption, if the drug isn't getting into your body quickly, then, or at all, then that's going to affect or how big a dose you need to get to the same blood level. And a previous talk I've given is on how acidity can affect absorption. Another significant factor that's increasingly common is bariatric surgery. So either gastric or intestinal surgery can affect absorption and how much of the drug is getting in and how quickly it's getting in. Distribution, so how the drug is sorted out within your body. And big factors there are the same weight person, if they have a big body muscle mass, is going to distribute drugs differently than if a significant proportion of their body is fat. So body size matters, age, and particularly as we get older, muscle mass tends to decrease. The percentage of fat does tend to increase, and there are gender differences in the fat water content of bodies. So all of those have some role, but again, there's certainly very big people who get away with small doses of stimulants. There's people who are normal size who need larger. So even though body size is one factor, it's not purely determinative. The integrity or how well drugs, getting back to distribution, cross the blood-brain barrier, and particularly people who've had immunologic problems, autoimmune problems, head trauma, all of these seem to have potential impact on some people's blood-brain barrier that drugs are more easily able to cross and you may need or get away with or require a smaller dose. Probably bigger than distribution or an absorption for most people is actually metabolism. So, and that's largely with the stimulants, how quickly P450 enzymes break down and get rid of the stimulant. And particularly 2D6, which is one isoenzyme or form of that, and the 2D6 can be interfered with by things like bupropion. So bupropion and several other antidepressants can boost levels of stimulants. So the one big factor for P450 is just which genetic form of a specific enzyme you've inherited. So you can get genomic studies, Genomind, GeneSight. There's more than 20 different companies in the US. I have a talk, it's a few years old now, but I think it is still current in terms of you can pay a lot of money for these tests, and most of the time they're not adding much clinical value. It's not that this isn't a real phenomena. It's that one thing is that in addition to which form of the gene you inherit, that's not necessarily telling you how well that gene is being expressed. So there are epigenetic factors, how well the gene is methylated or otherwise activated or inactivated that are, if you have a active form of the gene, but it's actually inactive in your body, it doesn't matter that you inherited a highly active form, or if your body isn't producing much of it, it's not being transcribed properly. Then, so epigenetics are at least as important as genetics in the metabolism of drugs. Probably receptor density has a factor, and this has not been rigorously studied extensively, but you would think if you have twice as many dopamine transporter molecules, then that would have an impact on how much drug you need to have a big effect in the brain. There's been sort of an assumption that some of the receptor densities track or correlate with severity of symptoms. But that's not very well established. But severity of the condition itself probably does have some general correlation, but lots of times that's also, again, an assumption that, if you have a mild case, you're only going to need a little bit of the drug. And if you have a severe case, you're going to need a big dose. There may be, again, some general correlation, but it's really loose and really poor, and there are people who seem to have mild forms who need a substantial dose of a stimulant to get a response, and people who have severe doses or severe conditions who respond to smaller doses. Since I've talked about it in a separate issue, in a separate video, I'm not going to go into it here, but some people do develop tolerance over time to these medications, so they may need a bigger dose. My clinical experience and most of what my ADHD colleagues are reporting is that most of the time, once a dose is stable and works, that tends to work for most people with ADHD over a period of many years. Another factor in terms of how big a dose people need is we know that absolutely most people with ADHD show considerable day-to-day variability and severity of their symptoms. A big factor contributing to this is how well they slept the night before. That is clearly not the only factor. There's some days people wake up and feel really with it and together and firing on all four cylinders, and other times people are waking up thinking, I'm just out of it today and I know the whole day is going to go like this. And many times on those bad days, a bigger dose is helpful enough, and on the good days, a smaller dose can be useful. We won't get into the philosophy of whether people should be manipulating their dose on a daily basis, but again, when we're talking about what's a high dose and what it means. So again, my recommendation is pay attention to the benefits you're getting. If you're seeing improvement in symptoms, great. If you're not seeing side effects, great. And if you're starting on a medication, for most classes of medications, I believe in start low and go slow. There's certain things like in antibiotics where you start at the standard dose and you keep at that dose because that's what you need. But with these stimulants, my recommendation is start low and go. If you are not seeing a response in 2 to 3 days, there's absolutely no point in sitting for a week or 2 weeks at a very low dose. You should keep titrating up until you are getting some adequate response, or until you are getting side effects that indicate I shouldn't go any higher. So in terms of dosing, I've talked in other videos, the highest doses I believe I've worked with were sisters. One was on 180 milligrams of Adderall, one's on 240. Right now, those individuals are in a different state, so I am not working with them right now. I do have one patient, a highly muscular professional bodybuilder who's on 180 milligrams of Adderall. I don't have anyone else close to him right now. He's been stable and steady at that dose and with benefits and without side effects. So as long as I document that, I'm comfortable with him prescribing that. And when I checked and researched for this, there's at least a case report of an individual. He was a youngster, and this was through his teenage years, was for more than a year on more than 4,000 milligrams a day of methylphenidate. And then towards the end of this case report study, was taking 7 54 milligram Concertas, so 370 milligrams a day for at least 2 years with benefit without apparent side effects. So again, we're treating people, don't freak out about the numbers. Now, if you're having problems, and again, the higher you go, the more at risk are certain problems, but pay attention to what's going on with your body or your patient's body and brain, not with the numbers. So looking at some of the studies, there was a meta-analysis in 2022 by Michael Block and colleagues at Yale, and they looked at 65 randomly controlled trials. This was looking just at children, included almost 8,000 children. And the big outcome from this study, a study of studies, was that if you looked only at fixed dose trials, and I'll say what, so it was comparing, part of what it was doing is comparing fixed dose trials to flexible dose trials. In a fixed dose trial, they say everyone's going to get 10 milligrams for the first week, and we'll go up to 20 milligrams for the second week and 30 for the fourth week. And if you don't tolerate it, you drop out of the study. That's a fixed dose trial. A flexible dose trial is you start with 10 milligrams for everyone. The people who are responding and getting a good response on week 2 may be staying at 10. The people who aren't then go up. And you go up at usually measured intervals, but you go up based on individual response, and the dose is adjusted to, according to optimize the fit. And in their study, so it's often easier to organize and plan a fixed dose trial. Many more studies are fixed dose trial than flexible dosing, even though flexible dosing clearly has much more relevance to, I would say, hopefully the real world. Hopefully most doctors in their offices aren't just saying everyone belongs on 10 milligrams per week, and maybe they are. So in this comparison, and this is a generalization, but there was a plateau with the fixed dose studies that once you hit about 30 milligrams of methylphenidate or 20 milligrams of amphetamine a day, it was hard to see any increased benefit by going up higher on the dose. Withdrawal rates or problems did keep going up the higher the dose the individual wound up being on. However, if you looked at flexible dose scheduling studies, then across the whole dosage range that was looked at, the bigger the dose, the more benefits you got. Again, these were studies in children, and that was both with methylphenidate and with amphetamine. So whether you were high, if you were low, you correlated with some small benefit, and the higher you went on the dosage, the bigger the benefits were on a flexible dose schedule studies. So this study was somewhat different than a large study that was reported earlier this year. Louis Farhat, Brazilian Sao Paulo University, but it was an international study with US and other researchers. This was a study, a meta-analysis again, but it was all in adults. Again, they were only looking at randomly controlled trials. 47 different studies made it into this, covering about 7,700 subjects. So again, almost the same size study, meta-analysis, as the child study. Most of the studies that were included were fixed dose, just because that's what were there, and some were flexible dosing schedule. And what they found, in contrast with the kids, this meta-analysis, was that with Ritalin, methylphenidate, improvement increased throughout the range that was studied, all the way up to 85 milligrams a day. However, once you hit about 60 milligrams, which is the federal cutoff, or again, recommended dose, and they used I think they were trying to be non-political or non-charged, but the title of their article is something about licensed versus unlicensed doses. So they labeled everything above 60 an unlicensed dose. Again, the FDA explicitly is not licensing it's making a recommendation about dose. It is not saying it is unlicensed or inappropriate to use a higher dose. So I think I really actually detest the language used there, making it licensed versus unlicensed. Anyway, in the 60 to 85 milligram range, the rate of improvement as you increased the dose was somewhat smaller, so it wasn't increasing at the same rate, but it was still increasing across the dosage range. In contrast, the amphetamine studies, and they noted that there are substantially fewer of them, but with amphetamine, there was a dose response curve, so between 0 and 30 milligrams, the upper recommended licensed dose, there was a linear relationship between bigger dose, bigger benefit in terms of reducing ADHD symptoms, but that completely plateaued at 30 milligrams. There was no increase as you went above 30, and they studied a range up to 75 milligrams in these different studies. So there was no apparent increase in going higher with amphetamine above 30, but side effects, or as measured by dropout rates or tolerance, did the bigger dose for both methylphenidate or amphetamine. As you kept going up, more and more people withdrew from the study. And fairly prominently, they summarized in their summary boxes for their study was that unlicensed doses of stimulants may not have positive risk benefits for adults with ADHD. And this was further dumbed down in the popular press to, this study proves that there's no benefit to going higher than the standard doses for ADHD. That's absolutely not what this showed. This showed, again, so for one thing, the authors of the study indicated that the data for amphetamine was, quote, of very low certainty of evidence, so very poor, not much to go on, if garbage in, garbage out, and not to insult the researchers, but of the individual studies or the meta-analysis there. But it's a very weak conclusion, and buried in their summary, they say, our study does not provide evidence that practitioners should not trial unlicensed doses of stimulants in routine clinical practice. Or to get rid of the negatives, is that it's completely appropriate for practitioners to adjust the doses of their individual patients, including going above the suggested recommended dosages. So again, part of this, very few studies of amphetamine, part of it is dependence on fixed dose studies, which may have much less relevance. And again, even studies are looking at averages. This is not telling you what benefit an individual is going to get or not. So looking at the a little more detail on the downside of the situation, rather than just the benefits, what are the risks of going higher? And again, most studies show that the number of nuisance side effects, annoying things, irritation, insomnia, decreased appetite, and again, not that some of those can't be serious, but they're not likely to be acutely life-threatening. Those pretty clearly, in my clinical practice, are more likely as you go higher with the dose. But what about the dangerous risks? So we've had lots of experts, sort of sharing their clinical impressions over the years, and not a lot of hard data. So one study in 2005, this was looking at patients not with ADHD, but on stimulants for narcolepsy and other excessive daytime sleepiness problems. And they just broke the group into whether you're on a high dose or a low dose of the stimulant. And the averages were, for Ritalin, the high dose group was on average, median I think, was 195 milligrams versus 60 milligrams. 60 in itself would still be considered at the high end for ADHD treatment. In the amphetamine group, it was actually, the high group was just 40 milligrams versus 30. The vast majority of people in this study were on methylphenidate. And in their study, the risk of psychosis was clearly higher in that high dose group than in the standard group. The risk of increased blood pressure was not increased didn't correlate with dose. The risk of cardiac or tachycardia, so irregularly fast heartbeat, was increased by the higher dose. And they also summarized a range of previous studies showing that increased blood pressure, hypertension, did not seem correlated in more than, I think, close to a dozen different studies with stimulant dosing, which would be surprising to most people. So I do have another talk on cardiac effects. What we see there is it's the duration of time on the stimulant, and again, less clear-cut. Logically, you would think high doses are going to be more risky there, but other than, again, for maybe arrhythmias, irregular heart rate, rapid heart rate, the data is not as clear-cut. For addiction data, and I have not looked at it really closely recently, but when I looked a few years back, there's almost no good data on risk. What are the rates of falling into addiction problems from people who are on stimulants? I mean, part of it is that the addiction data is buried and confused with the misuse data, where misuse is any deviation from using it exactly as prescribed. That most of the people in those studies are not addicted, are not abusing their medication. So true addiction problems, the standard expectation is bigger dose of stimulant, you're more at risk. Very little data that actually show that so. That doesn't mean it's not so. And then the question that I think has been chronically underaddressed is the risk of psychosis. It's a rare risk. There's debate about whether it is only a risk with amphetamine products and not with Ritalin, or whether it's generic to all stimulants. I think there's growing evidence that it's certainly more closely correlated with amphetamine use than with methylphenidate risk. And there's a study that just came out. It's actually not even officially out. It's a pre-release this week by Lauren Moran and colleagues at Harvard McLean University Hospital addressing rates of psychosis depending on stimulant dose. And it was particularly methylphenidate use did not seem to correlate with psychosis. So one, the design of the study was looking at everyone admitted to McLean over, I think, a 15-year period. With the first occurrence of psychosis, they had 1,300 cases. They matched those to two control cases for every psychosis case, and they matched them on gender and education and diagnoses and a few other things, So other patients in the McLean system, most of these new psychoses were described as psychoses. About 10% were thought to be pure mania and 30% mania with psychotic symptoms. But what they found was, if you looked at amphetamine prescription use in the month preceding hospitalization, there was for people on high doses of amphetamine, defined as greater than 30 milligrams, the odds ratio, you were 5 times more likely to be hospitalized for psychosis. If you were in the moderate range of 15 to 30 milligrams a day, you still had an elevated risk, 3.5 milligram, or 3.5 is the odds ratio for being hospitalized with psychosis. And if you even had a low dose of amphetamine, less than 15 milligrams a day, your risk was still almost twice the control populations for having a psychotic episode. So what they remarked, one is that even their high dose cutoff wasn't particularly high, so that 30 milligrams was actually a dextroamphetamine equivalent, which equates to about 40 milligrams of Adderall or about 100 milligrams of Vyvanse. So their high-risk group were people higher doses bigger than that. And again, this was a correlational study. It can't show proof of causation. They did concede that it's possible that there was a confounding variable. Maybe more people with more severe ADHD are themselves at greater risk for psychosis. That's a possibility, but if that were the case, then you would think that your methylphenidate dosing in the month before being treated or be admitted would correlate with that, and it didn't. Again, there was no correlation with being on Ritalin at all and having a hospitalization for psychosis. And they also brought up that reverse causation could be at play here, and that would look like this, and that would be the people who actually eventually developed psychosis actually had preliminary signs of psychosis. So we know that psychosis, people with schizophrenia or many other psychotic conditions, aren't just having delusions and hallucinations, they're also having cognitive problems. So it could be that the very early preclinical signs of psychosis mimicked, overlapped, co-occurred with ADHD and made it that these people needed higher doses of the stimulant. And that's, again, so that the association was coming from these were really people who were pre-psychotic who wound up on higher doses rather than just that higher doses of stimulants cause psychosis. Anyway, what they concluded was the amphetamine dose is the most important modifiable factor for psychosis risk. So that was one thing that could be changed, could be altered. The bigger you go, the higher the risk. Most people, even at big doses of stimulants, or big being within, I would say maybe not the massive dose that the case report I cited, but most people with even large doses of stimulants are not becoming psychotic. So I'm going to end and sort of wrap things up because I may be repeating myself a little bit here. There was editors of the Cochrane study. So the Cochrane study is a entity organization that reviews particularly psychiatric literature and comes up with, distills recommendations for medication, mostly use, some other treatments as well in the psychiatric mental health realm. And I just found their summary one of the statements really disturbing, which was, these medications aren't, so talking about stimulants, these medications are inherently rewarding, which means we can't take a purely collaborative approach and let patients guide the dose. So I would, maybe it's a semantics or a language issue, I would say almost exactly the opposite. You always have to be taking a purely collaborative approach. You always have to be eliciting information from the patient because that's who you're treating and that's how you're going to see Are we having benefits for the individual? Are we having detrimental effects? Again, yes, let them know as we go higher the risk for psychosis, the risk for addiction, the risk for cardiac effects may well be increasing, but just because you may also have a pleasurable, rewarding effect from the medication doesn't mean we should be depriving an effective medication from you. So that's what I have to say. And stay healthy, stay happy. I'll be open to questions and answers on this in a few days. That's all.